And all the credit goes to our chairman and the managing director, Professor Natarajan. So, sir needs no introduction, and I would welcome Professor Natarajan sir and Professor JB sir to this Jyotirmay Biswas sir, who is known as JB sir at Shankar Nethralaya. So, Natarajan sir, as you all know, is a world-renowned vitreoretinal surgeon, and is a Padma Shri awardee and immediate past president of the All India Ophthalmic Society. So I welcome you all. Natarajan sir, please, you can take over now.
Thank you, Hitesh, and I'm happy we are having a Shankaranethala extended family here at Aditya Jyot, and thanks to you for your introduction. Dr. Badrinath inaugurated in July 1990, and that time 6 consultants came, and after that Dr. Bishwas is a great support. I'll share the screen. So I'm happy to introduce Dr. Bishwas. He actually does not require any introduction, but I think it's my pleasant duty to do, because he's the hero of the program. And not only that, he's the hero of uveitis in the world. And Dr. Jyotirmay Bishwas specializes in uveitis and ophthalmic pathology. I'm glad to know in and out of Dr. Jyoti, we call him, Dr. Badrinath used to call him Jyoti, and even Narsingh Rao, his mentor, used to call him Jyoti, but I call him JB. And I'm happy I know in and out of JB right from his King's Hostel days to what he's in now. And he did his MBBS from Medical College, Calcutta, and post-graduation ophthalmology from PGI Chandigarh. And he did his fellowship in vitreoretinal surgery. He was 6 months senior to me, 2 years fellowship in ophthalmic pathology from Doheny Eye Institute, University of Southern California, USA. And I still remember very happily that me, Dr. Badrinath, Mrs. Badrinath, went to the airport to see him off to go for the ophthalmic pathology. And still we are sending epiretinal membranes to him from Shankar Nethralaya. And I think I got an excellent certificate because of him and Dr. Narsingh Rao. And before this, what is not here is before his MBBS, he was in a town, I think a small town village in Calcutta, in West Bengal, where I think he didn't have electricity also. But you can see he has published 407 articles in peer-reviewed journals, which is one of the highest in the world for an individual like him with his age and his capacity as a consultant. And I think it's really amazing. We both started the career same time, but he's got almost twice my publication list, and also 10 times my chapters, like 47 chapters in books of ophthalmology, 32 papers in international conferences, and 170 papers in national and state conference. He had given 280 lectures in international and national conferences, and he's reviewer of 36 journals. It's not easy. It's a lot of hard work. And I think he has learned from Dr. Badrinath, it's not hard work, he works passionately. So it's no work at all. And he has received 33 awards, and it's not easy. All the awards are not simple, like a Hari Om Ashram Award for clinical research from Medical Council of India, member of International Uveitis Study Group, American Uveitis Society, and Executive Council member of the International Ocular Inflammation Society. He was the first to describe ocular lesion in AIDS in India. His current area of research is uveitis, AIDS, and Eales disease, and he is a visiting professor at Advanced Eye Care Center at PGMR Chandigarh. And Dr. Bishwa is also a marathon runner, recites Bengali poems, and writes Bengali articles and received many awards. And the other one is, I remember he worked in the Madras Tuberculosis Center and examined 1,005 tuberculosis patients in the center in Chetpet, and then found nobody had Eales. And I think he proved it reverse, and I think he's done also a lot of extensive work in Eales disease. And I think he's also written a treatise on Eales disease in Survey of Ophthalmology. And I think we can go on and on. The reason is I'm proud that he's a pure India make, made in West Bengal, then Chandigarh, and then Madras. And I'm happy to say I'm total Madras make, and I'm his junior, and I'm proud to say that I'm his junior. Luckily, the age does not change. He is going to be my senior all the time. And with this, I will give a brief introduction of to uveitis. And I'm glad we have the 30 years of Aditya Jyot, compassionate eye care to the people of India. And I'm glad, thanks to my mentor, Dr. Badrinath, and my second mentor, Raja Jovanovich, who has taught me how to do a passionate eye care, including Dr. Abdul Kalam, who gave me a book called Compassionate Eye Care by Robert Schlim, Dr. Robert Schlim, and the first Dalai Lama Rinpoche. And the whole thing is like what is uveitis, an inflammation of the uveal tract, iris, ciliary body, and choroid, and an associated factor of neighboring structures, retina, vitreous, optic nerve. And when we were doing fellowship in retina vitreous surgery, even Bishwas was doing retina vitreous surgery, then he branched off to ophthalmic pathology and uveitis. And I think he has taken up the uveitis as a great branch. And I think now people are doing fellowship in uveitis. And that's how Dr. Hitesh Sharma is a fellow of Dr. Bishwas. And we have Dr. Jaydeep here, who's a vitreoretinal surgeon, a fellow of Shankar Nethralaya, and he's again a DNB from Aditya Jyot. The International Uveitis Society group classification, and Bishwas is the integral part of this classification. The group in infectious, non-infectious, and masquerade, and the subgroup bacterial, fungal, viral, parasitic, and others, and non-infectious, known systemic association, and no known systemic association, and masquerade, neoplastic, and non-neoplastic. And the type, it could be anterior uveitis. The primary site is anterior chamber, includes iritis, iridocyclitis, anterior cyclitis. And intermediate uveitis with the primary site is vitreous, which includes pars planitis, posterior cyclitis, and highlightis. Posterior uveitis, the primary site is retina or choroid, focal, multifocal, or diffuse choroiditis, chorioretinitis, retinitis, retinochoroiditis, and neuroretinitis, and panuveitis, anterior chamber, vitreous, and retina or choroid. And I think I remember Dr. Bishwas taught me when I referred him a patient whom I did multiple vitreoretinal surgery, and I suspected a system, the sympathetic ophthalmia, and he told me, he calls me Natty, and he said, don't worry, it is a panuveitis, and it's a bilateral panuveitis, and we'll treat them, and you detected the patient early. So I remembered the Parsons description of the first sign will affect the near vision and like the accommodation, and that's how I identified in a young girl who developed sympathetic ophthalmia. And pathological classification, you have granular matters and non-granular matters, large greasy mutton fat capes, iris nodules, cape and pusaka, and the non-granular matters, confluent, fine, white-colored, small, which comprise of the lymphocyte, plasma cells, pigments. And descriptors of clinical behavior, the onset, sudden or insidious, duration, it's limited, less than 3 months, persistent, more than 3 months. The course, acute, sudden onset with limited duration, recurrent, repeated episodes, inactive periods, more than or less than 3 months of treatment, chronic, persistent, relapse, and less than 3 months of treatment. An approach to a case is for a uveitis, a brief pulse, and I'm sure we are going to have our keynote speaker and the chief guest, Dr. Bishwas, who will do justice to this. Approach to a patient of uveitis, symptoms. And I think all this is given in Tirukural as a Noinadi, Noimadal, that means you find the root cause of the disease and treat, and don't treat the symptoms. But the patient will report you with symptoms, anterior, the photophobia, redness, watering, pain, under reduced visual acuity, may be asymptomatic, intermediate, floaters, photopsia, reduced visual acuity, and posterior, reduced visual acuity, photopsia, floaters, scotoma. And presenting complaints could be previous episodes and investigation or surgery or trauma, and past medical history, arthropathies, example, ankylosing spondylitis, chronic infections like herpes simplex virus, tuberculosis, systemic inflammation like sarcoid, Behçet's disease. Systemic history, detailed review of all systems. And I'm glad I learned this from Bishwas, how to take history. And I'm very compassionate about taking history from a patient, and not only medical history, as a systemic history. The reason is, it's not only ophthalmic history, you have to treat a patient as a whole, because eye is a continuation of the whole body, and I think we should know that. And then a family history, family members with uveitis are related disease, surgical history, travel, residence abroad, pets, IV drug, sexual, and then drug history, including any systemic immunosuppression, allergies. Allergies are relevant contraindication, visual acuity, best corrected or pinhole or near vision, visual function, check for RAPD, color vision, conjunctiva, circumcorneal injection, cornea, band keratopathy, keratic precipitates, distribution, size, pigment. The reason I'm showing you all this is, in the eye, I always tell three things are there: either vision, eye is red, or pain. All the three comes under any disease in the ophthalmology. So we have to learn all this and approach to the clinical thing: antechamber, the gonioscopy, iris, lens, tonometry, dilated fundoscopy, examination of the vitreous, the optic disc, the vessels, the retina, choroid. And I think you have to have a systematic way to examine the patient, and grading of cells from 0 to 4+, and activity from 0 to 4+. And then here you see the signs KP, and then both the size and distribution of KP are helpful in the differential diagnosis. And I'm not going into details. And then here you're seeing the sciences with the posterior sinus cave, the line diagram, as well as the slit-lamp photograph, iris atrophy in a patient with the herpes simplex virus, associated anterior uveitis, vitritis with the patient with the vitreous haze, and then PISA-PI in a CMV retinitis, frosted branch angiitis, and then acute retinal necrosis. And still I remember myself have treated an acute retinal necrosis patient in Shankaranatalaya, which finally turned up with a retinal detachment later and operated with vitrectomy and silicone oil in '86. And this is again a differential diagnosis is very important, because most of the time it is overlapping with the features, the difference between this is red eye, acute conjunctivitis, acute iridocyclitis, and acute congestive glaucoma. I'm sure the following speakers will show the differences. I'm sure with the erudite presentation from JB, you will know more from all this, the differential diagnosis and investigation. And I think it's a band of energy, investigation required. And I remember every time Professor Narasimha Rao comes to Bombay, I used to make him give a talk, and he used to tell, don't investigate a patient without the basis. So that means for every patient, don't ask for the list. And you have to have a set pattern. You have this symptom, you have this findings, you have this slit-lamp findings, and then the systemic findings, then order the instrument accordingly. So I'm not going to read everything, and I'm not going to tell also everything. Investigation in a diagnosis of the uveitis patient, and complication that can be vision threatening if not treated early is the band-shaped keratopathy, complicated cataract. And I think we are here as ophthalmologists to address the general ophthalmologist is to prevent this complication. Glaucomatous optic neuropathy, which is hemorrhage, exudative retinal detachment, choroidal detachment, non-glaucomatous optic neuropathy, choroidal neovascularization, subretinal fibrosis. Because it's a chronic problem, can lead to all this. So the take-home message is uveitis is a vast specialty with a myriad of signs and symptoms. And that is why we need a master. And for everything, we need a mentor, whether it is sports or whether it's ophthalmology, we need a mentor. And for uveitis, Dr. Biswas is one of the greatest mentors in the world, not only in India. And uveitis connects the eye to the rest of the body. When diagnosing, keep looking everywhere. You may find the answer to the ocular pathology in the systematic illness or vice versa. Eye is the window of the body, and a keen observer is all it takes to catch it. Here, the statement which is there is, what the mind does not know, eyes do not see. And don't turn a blind eye to everything. So you have to see the patient as a whole, and multidisciplinary approach to the treatment. You need systemic treatment with anti-mitotic treatment. So you have to involve physicians, internists, and doctors of many specialties, rheumatoid specialists working in tandem. Strong doctor-patient relationships to keep the patient on good medication, compliance, and follow-up. So documentation, referral by writing, then follow-up. And then if there's a follow-up problem, we have to have the counselors to call them, make sure they are following the treatment, they are looking for the side effects. And I'm glad every time when I send a patient to Dr. Biswas, he sends such a detailed report, and he also calls me, tells me that I've done this, and please make sure the patient comes back to me in 6 weeks, 2 months, like that. And I'm glad we have now Dr. Hitesh and Dr. Jaydev who takes care of it. So with this, I think I thank Dr. Hitesh for asking me to give this talk, and it was actually not required. I should have just introduced the subject, but I didn't have time to refuse it, so I had to do this pleasant duty. And thanks for asking me to share this. Now I am stopping sharing my screen, and everything to you, to Dr. Biswas and Hitesh. And I would like JB to give a comment before Hitesh starts it. Is Jaydeep going to introduce Hitesh? Jaideep,
Yes.
I think you should give a, or maybe JB should introduce Hitesh.
I think JB sir can introduce, sir.
Yeah. So JB, you can give a comments on my introduction.
Yes,
Then you can introduce Hitesh.
I think Nati is a complete vitreoretinal surgeon as well as a nice person. He gave an overview of what is uveitis, and what is very true is that uveitis is associated with a systemic disease, and we need to have a holistic approach, and is rightly pointed out by him. With these things, I wanted to introduce Dr. Hitesh Sharma, who did a fellowship with me in uveitis, and he did research work, particularly in swept source OCT in VKH, which was published in Ocular Immunology and Inflammation Journal. This was a great job. He did a really hard work, and he is very meticulous in evaluation and treatment of the patients. Anytime any patients with sensitive, he always gives me feedback and see that whether he's in the right direction or not. He's a very nice person also, and a very keen observer. With these words, I introduce Dr. Hitesh. I request Hitesh to give an approach to a case of uveitis.
And I also want to thank JB, who really insisted, because when he sent the CV, I think probably I was traveling, so I didn't answer him. And I'm very happy that he's a perseverant, persistent mentor for Dr. Hitesh. He called me and said, nothing doing, you go through him, and I think you have to take him. It will be advantage to as a joke, rather reverse. So I'm glad I took him. And not only that, Dr. JB was kind enough as a great mentor like Dr. Badrinath. He came and inaugurated the clinic. And I respect that, because I always respect Mata, Pita, Guru, Mitra, and Deva. And I'm happy that Hitesh is respecting the Guru, that is Dr. JB. And JB came as a Guru and opened the clinic. And I'm glad Hitesh was insisting that I should be there. And I remember, I hope Hitesh can show the photograph of my grandmother, JB, and coming to the clinic. Maybe you can ask your wife to pick up the photo by the time you finish your presentation. With this, I'm glad, Hitesh, you are working with us. I'm glad I didn't realize I have a bunch of Shankaranathala trained people working with me. And I'm really glad. I'm sure, I hope Dr. Badrinath can see this recording. And I will send this YouTube recording to Dr. Badrinath, and I'm sure he'll be happy. I'll do that. I'll make sure he sees this program so that he knows how much we love JB and how much JB loves all the Shankaranathala alumni. With this, Hitesh, I think all yours.
Yes, sir. Thank you, sir. Thank you, JB sir, for the kind introduction, and thank you, Natarajan sir, for the kind words. So I'll start my topic on approach to a case of uveitis. Next, so I don't have any financial interest. Next, so as Natarajan sir already has introduced about the uveal tissue, which is comprised of iris, ciliary body, and the choroid. So it's very pigmented vascular structure, and inflammation is known as uveitis. And so the structures marked in red is the uveal tissue. So next slide. So according to the classification, it can be anterior, intermediate, posterior uveitis or panuveitis. So symptoms, as Natarajan sir has said, that red eye, visual disturbances, pain, floaters, photophobia, photopsia, irregular pupil can be the symptoms. And signs, there can be circumciliary congestion, keratic precipitate cells, hypopyon, fibrin, and posterior segments, many times vitreous cells, exudates, granuloma, retinitis, choroiditis, vasculitis. Next slide. So many times we get confused about the red eye. So uveitis commonly presents as circumciliary congestion. It is more angry looking. Next slide, please. So uveitic eye would look more angry looking like this. It will have a circumciliary congestion, and the cornea can be hazy. Next. So causes can be, a huge list of causes are enumerated, which are like can be intermediate, anterior, intermediate, and posterior uveitis. Depending on the segment involved, the causes can be enumerated. So according to etiology, it can be infectious, non-infectious, trauma, medication-induced, or any masquerades. So point to be discussed is main thing to approach in uveitis, as Natarajan sir already has said, that history taking is very important, and identifying the pattern of uveitis is the most critical step I feel should be done. And looking for complications, workup, treatment, and counseling. Counseling is very much important as it is quite recurrent and it is quite chronic in many patients. So history taking, you should know the demographics of the patient, the sex. If the patient is a child, it can be JIA, young patients, HLA-B27 associated, middle-aged sarcoidosis, elderly can be masquerades, and you should enumerate the past history, and you should always go for the external and the general physical examination, like the posture of the patient, like the posture can be typical as in case of ankylosing spondylitis, or the patient can have a typical arthritis as in rheumatoid arthritis. So history taking, listen to the patient's complaint, give time, ask for treatment history, any worsening side effects, ask for recurrences, frequency, severity, and look for any other significant uveitic history like Cox contact. So pattern of uveitis is very important, and hence proper examination with vision checkup, intraocular pressure checkup, and a complete dilated evaluation is very important at all follow-ups. So points to be noted. So whether the onset, is it acute, recurrent, chronic, and whether it is non-granulomatous, granulomatous, you have to identify the site which is involved, anterior, intermediate, posterior panuveitis, and see whether it is unilateral or bilateral, and whether it is tentatively like infectious and non-infectious, and make a provisional diagnosis. So it can be non-granulomatous, granulomatous. So non-granulomatous can be can have fine KPs, and next. So it can have fine KPs, as you can see in this fuchs-like uveitis. There are diffuse stellate KPs, or granulomatous uveitis. It can have these mutton fat KPs. And then the scleritis and episcleritis, very commonly confused entities are scleritis, episcleritis. So scleritis will be more red, angry looking, and as you can see in this picture, even after dilatation, the redness still persisting, and the patient will complain of pain. And episcleritis, it will be mild, recurrent, and it goes off with only topicals. And scleritis is very important to diagnose, as it can be associated with various systemic entities. So if the patient is having unilateral stellate KPs, which is diffuse in distribution, and there is absence of posterior synechiae, iris atrophy, posterior subcapsular cataract, it can be Fuchs heterochromic iridocyclitis. So these patients usually present with posterior subcapsular cataract, and counseling is very important, that after the cataract surgery, patient would complain of floaters. Or in such a situation where there is acute severe fibrinous non-granulomatous reaction, and this can be HLA-B27 associated anterior uveitis. And if it is the first episode, you should always think of endophthalmitis. So always do a B scan before approaching to any other step. So it can be hypopion uveitis. Hypopion uveitis is usually associated with ankylosing spondylitis, Behçet's disease, infection, any lens-induced uveitis, or it can be any masquerade or malignancy. So IL-related uveitis, if the patient is pseudophakic and there is recurrent uveitic episodes, it can be IL-related. So always suspect low-grade endophthalmitis. So if there is uveitis with hyphema, it could be post-traumatic or post-viral. And if there is sectoral iris atrophy, raised IOP, recurrent anterior uveitis, it is usually viral anterior uveitis. And if there is those mutton fat KPs, and these are usually bilateral, and there are nodules involved, and these are usually granulomatous uveitis. So patients who are having bilateral snowballs and snow banking with CME and persistent vascular sheathing, which are peripheral, can be tuberculous or sarcoid. And in idiopathic cases, there are known as pars planitis. So these are like intermediate uveitis. And distinguishing between retinitis and choroiditis. So retinitis will be a more whitish patch, irregular, and choroiditis will be yellowish patch, and you can see the blood vessels over the choroiditis patch. So it's very important to distinguish between retinitis and choroiditis. And if there is typical headlight in fog appearance, having a unifocal necrotizing retinitis, the most common is toxoplasma retinochoroiditis. So it usually heals very well with anti-toxoplasma treatment and steroids. So if there are choroidal nodules, always rule out TB and sarcoid. So large confluent serpiginous lesions starting from the optic disc is usually known as the serpiginous choroidopathy or GHPC, geographic helicoid peripapillary choroidopathy. So differences between GHPC and the serpiginous like choroiditis or the tuberculous choroiditis, that in GHPC it usually starts from the disc and there is little or minimal vitritis, and in tuberculous one there could be multifocal lesions in the mid periphery, usually away from the disc, and there could be foveal sparing. In spite of extensive choroiditis, the vision could be very good. So in patients with active vasculitis seeding, there is retinal vasculitis, always rule out TB sarcoidosis and do an angiography to see the pattern of leakage. So if there is, as Sir said, that there is retinitis with frosted bands angiitis, it could be CMV retinitis. And exudative retinal detachment. So exudative retinal detachment, if there is, you do an angiography, if there are multi-pinpoint leakages and there is late pooling, it can be VKH. Or if there is unilateral with pain patient, you do a B scan. If there is doubt of any posterior scleritis, the B scan will pick up the T sign. But do remember that in exudative retinal detachment, do an angiography to rule out CSCR, as the treatment would be completely different. Next slide. So panuveitis, if it is vasculitis, it could be Behçet's TB or sarcoid. Choroiditis, retinitis, it could be TB, viral, Behçet's, hypopion, Behçet's, or any infective etiology. And exudative RD, it could be VKH or sympathetic ophthalmia. So conditions mimicking panuveitis, you have to remember it could be endogenous endophthalmitis or large cell lymphoma, which could be masquerades. So last but not the least, medication-induced uveitis, which are well described, uncommon, but usually causes very mild reaction. So most commonly seen are the bisphosphonates, which are inhibitors of the bone resorption, commonly given and usually seen after the patient has taken the medication, and it will present as scleritis. So take-home message is that uveitis presents with varied clinical signs and symptoms, a thorough history taking with careful clinical examination, systemic and ophthalmic, very important, and a tailored lab investigation is very important. And as Sir has said, that multidisciplinary approach is very important. So I'll just conclude with this, thanking the UVR department from the Shankar Netralaya, and I would ask JB Sir, who is the chief guest speaker at this webinar, to start with his talk, sir. Thank you, sir.
Share the screen. Share the screen. Where is this? What the screen is doing? This one.
You can stop sharing, and then you can open the presentation, again stop sharing.
Yeah.
Sorry, sharing.
Yes. Yeah. So at the outset, I'd like to congratulate Aditya Jyot Hospital for 30th anniversary. It's a great achievement to continue as a 30-year of services to the ophthalmic community and the patients of ophthalmology. I thank Dr. Natarajan, who is junior to me in Shankar Netralaya, for a nice and kind introduction, and my dear fellow, Dr. Hitesh Sharma, to give me the opportunity. Today, I'm going to talk on pulse of diagnosis and management of uveitis. I'm not going to the details of that history taking and a textbook thing. I start with a kind of a so I'll give some practical pearls in the diagnosis and management of uveitis. I first start with in IT industry, they give birth to twins, and guess what they name them? Can anybody can tell them what they name? In IT industry, somebody gave birth to twins. Guess what they named them? It's copy and paste. So that a lot of times we see that the people put the copy and paste, but I am doing today is that my own experience, what is I have learned over the years and still learning the uveitis, some practical points. So first I talk about anterior uveitis, then intermediate uveitis, then posterior and panuveitis. Each part, after that talk, I'll get some questions. I'll answer some questions if it is there, and I'll be happy to answer. So I start with a case-based approach. A 35-year-old male had acute attack of pain, redness, photophobia, and the picture is like this: fibrin in the anterior chamber and hypopion. So what history you will take? The first question you will ask the patient is this the first attack or recurrent attack? And does the patient have joint pain, especially backache? Because that's the common cause of hypopion or fibrinous anterior uveitis. And you don't need a battery of investigations. You may need to do only one investigation, which would be HLA-B27 in non-granulomatous recurrent anterior uveitis with hypopion. So how do you treat it? You have to put the topical steroid and short-acting mydriatic cycloplegic agent. How frequently? As frequently as every 15 minutes, then half-hourly, then 1 hourly, and taper, not suddenly, by 6 weeks, slow tapering. And mydriatic cycloplegic agent, homatropin, 3 times per day. And if it is a fibrinous uveitis, when there is a chance of synechiae is more, few days of atropine will do well. So here is an example. Before treatment, you can see the hypopion as well as that fibrin in the anterior chamber. And you can see that the fully dilated people, congestion has gone and no fibrin is there with the appropriate treatment with topical steroid, frequent topical steroid, and short-acting mydriatic cycloplegic agent. But when you see this type of picture, a patient with granulomatous uveitis and Martin keratic precipitates is present over there, what do? You should rule out the two diseases. One is the TB, another is the sarcoid. You would be doing that Mantoux and quantiferon TB gold test, and X-ray chest, HSCT chest is better. And for sarcoid, you would do the serum angiotensin converting enzyme. You don't need to do a battery of the test. You do a tailored laboratory investigations. And if all the things are negative, then you can do an invasive procedure like anterior chamber tap and do that PCR studies to rule out any infective etiology like tuberculosis. Now, this is a patient who is having the granulomatous multiple pigmented keratic precipitates. What is the diagnosis in this case? Is you can the probability of the tubercular uveitis, viral uveitis, or lens-induced uveitis. But if you look at that lesions, you can see that there is a circumciliary congestion, and the capes are pigmented and all over the cornea, and the pressure is raised. In such cases, you need to skip the suspicion of viral uveitis. And in such cases with the suspicions, the best way is to do that, and if the facility is there, take a fluid from the anterior chamber and do polymerase chain reaction, real-time polymerase chain reaction here showing multiple copies of the viral DNA. And you can see the viral uveitis carefully, you would be seeing iris atrophy over there. There's another example of viral anterior uveitis, pigment dusting on the posterior surface of the cornea. But sometimes you will get patients with no pain, redness, and floaters. And these type of patients have got stellate keratic precipitates. And these are fuchs uveitis. They are all throughout the posterior surface of the cornea. You will be seeing no synechia and disproportionate cataract. In such cases, thus patients do not require topical steroid or even non-steroidal anti-inflammatory agent is not required. They do well, and with the cataract surgery, they do extremely well. They can have raised intraocular pressure. You do not require any investigations of such fuchs heterochromic iridocyclitis. And no need of steroid cover before cataract surgery, and you can get gratifying results with phaco and IOL. So what you look for in uveitis cases? You should define, as Dr. Natarajan has told, there is a circumcorneal congestion will be there, KPs will be there. This can be fine, small mutton fat, and you should distinguish it from scleritis, where it would be congestion in the sclera, or corneal ulcer, or conjunctivitis, where you won't see the keratic precipitate. They can have fibrin, hypopion, synechia, and iris nodules can be seen in granulomatous uveitis and iris atrophy in viral uveitis. Here is an example. You can see that this uveitis on the right side is an uveitis, hypopion and circumciliary congestion. And on your left side, you will see that there is a ciliary congestion, scleral congestion with the scleral edema. Right one is an uveitis, left one is a scleritis. The treatment is different in both the cases, where the scleritis will require systemic evaluation, much more details, and needs systemic treatment. KPs can be fine stellate, small size, and mutton fat KPs. Mutton fat KPs always indicate a granulomatous etiology. TB sarcoid is the most common possibility. You look at the KP carefully. Is it crenated? And if it's crenated, this indicates old uveitis, and they don't require treatment. Careful observation is enough. You look at the pupillary margin. At the undilated stage, you can see the nodules on the margin of the pupil. This is called Kopis nodule, or you can see the nodules on the surface of the iris, and this is called Busacus nodule. And these nodules in the iris surface or the margin indicates granulomatous uveitis. Such patients need to be investigated. And most important thing is that even if you see an interior uveitis, you will focus in the anterior vitreous phase and see that there is a cells floaters is there, vitreous prans is there. That will indicate that it is a spillover anterior uveitis. Actually, it was a pars planitis, and you can see the fundus examination with indirect ophthalmoscopy and scleral depression, multiple exudates in the inferior vitreous. Here you can see the inferior vitreous, multiple snowball exudates. So you should not miss an intermediate uveitis. Here is a patient with the anterior segment acute anterior uveitis, KP small to large, and raised IOP, and vitreous cells is seen over here. And if you will be surprised to see that this apparently looks like anterior uveitis, but if you do not do the dilated fundus examination with indirect ophthalmoscopy, you will miss the retinal finding. Actually, the patient was having acute retinal necrosis. In the periphery, careful examination will show the wedge-shaped retinal lesion. Wedge-shaped retinal lesions in the necrotic retina. And this is acute retinal necrosis, which is a real emergency, and you need to treat the patients with an antiviral intravenous dosage. So if you might find the KPs over there, there will be so much anterior chamber reaction that you may not be able to see the fundus. But whenever this reaction comes down to the treatment, you should at the earliest opportunity to see the fundus. Here in this case, though the patient presented with the anterior uveitis, fundus examination showed that there is an underlying toxoplasmic retinochoroiditis. There is a focal retinochoroiditis with vitreous haze. So indirect ophthalmoscopy is very important in a dilated eye, even there is an anterior uveitis. There is also the pediatric uveitis is a challenge. The children have got whole life in front of them. So it's very important to diagnose it promptly, properly, and put them on adequate treatment. This is an 8-year-old child. He has got joint pain and swelling in the right knee. No pain and redness of the eyes. Child was not able to see the blackboard properly. So patient was referred by rheumatologist. But by the time you see that there is a band-shaped keratopathy, as is shown by the arrow, black arrow, and there's a posterior synechia. These are the quiet eyes, white eyes, but the patient can have chronic anterior uveitis. In such cases, the diagnosis is to be made with the help of a rheumatologist, and it was indeed a juvenile idiopathic arthritis-associated uveitis. So in uveitis, particularly in children, you need a holistic approach. You need to collaborate with a rheumatologist or a pulmonologist. So next important point is that as the patient comes to you, you should look the patient as a whole. It should not be room light dim or room light off. You look at the patient as a whole. You can get the clue. See this patient has already on herpes-zoster skin lesions. If we have only put the patient on slit lamp, we may miss this kind of skin lesions, which can give clue. The patient's standing positions, the scoliosis or deformity of the joints can be easily visualized if the patient is seen in the room light on and have a look at the patient. So last but not the least, don't miss it. If you get an uveitis in the extremes of age, children, or in adults over 60 years of age, this is a case of a child who came from Goa, actually, 8-year-old girl, and he had an uveitis with hypopyon. It was not responding to the topical and systemic steroid. I was at the beginning of my career. I went to Dr. Badrinath. He said that, why don't you tap that anterior chamber fluid? We did the anterior chamber fluid tap, and what we found that basophilic cohesive cells suggestive of retinoblastoma. So we would have missed the diagnosis, and very important, not only for the eye, but also for the life of the patient, of a diagnosis of retinoblastoma, which can present as an anterior hypopyon uveitis. So in summary, don't think anterior uveitis is so simple. I'll stop at this stage and will audience, if there is any questions or anybody ask any questions, I can clarify or I can go ahead. So
you
any
can
questions?
continue, sir.
I'll continue.
We'll take the questions after we are
at the one. Okay.
Yes.
So now coming to the intermediate uveitis, 1 in 5 of the uveitis is intermediate uveitis. This is a 30-year-old patient, gentleman. He has only one complaint. There's a floaters. He doesn't have much dimness of vision, but he was bothered by the floaters. And if you look at the fundus, and if you look, good clinical slit lamp examination will show there is the anterior vitreous cells is present behind the lens. And you can see that the vitreous strands over there. And this patient actually having intermediate uveitis. So you need to do indirect ophthalmoscopy, careful indirect ophthalmoscopy and scleral indentation. You will find exudates in the inferior vitreous, indicating intermediate uveitis. Why is important? Such patients, though having floaters, they have underlying and inflammation in the intermediate segment, which can lead to a cystoid macular edema. They need systemic treatment or periocular treatment like posterior subtenon or even intravitreal Ozurdex injection. So if we see the foveal reflex dull, in that case, the earliest opportunity, you should show OCT, which will show the cystoid macular edema, which is quite common. About 20% of intermediate uveitis will have cystoid macular edema. You will see that macular edema is thickness and cystoid spaces in the macular area, as shown in the picture. If we do a fundus fluorescence angiogram, we will see the petaloid hyperfluorescence as seen in this picture over here in the late phase. So what should you do in this case? In our country, you should look for sarcoid first and then TB. And if negative, you should consider as an idiopathic. So what are the investigations you should do? You should investigate for the TB and sarcoid, as I've told you, Mantoux, quantiferon, serum angiotensin converting enzyme, chest X-ray, or CT chest. How to treat? The treatment is a very systematic way we need to do it. Schematic approach is given over here. First step, we can give posterior subtenon. If not responding, you go to the next step, oral prednisolone. If not responding, you give the immunosuppressive agents. And if not responding, then we'll take help of NATI. Vitrectomy will be requiring to reduce the reduce the vitreous inflammation. So how do you give posterior subtenon injection? What is the drug is chosen? Is triamcinolone acetonide is given in the posterior subtenon space, and patient can require 2 to 3 such injection. It works very well, but there is a 20% chance of rise of intraocular pressure. So you should be very careful, and the patient should be followed up after 2 weeks to see that the rise of rise of pressure. So when you give oral steroid in intermediate uveitis, if you see a bilateral case, you cannot give injections in both eyes at the same time. Severe bilateral cases, oral steroid will be a good choice. Periocular injection failed, you give oral steroid. What is the dosage? You should not start with a low dosage. You start with a really a good high dosage, 1 milligram per kilogram per day, taper by 10 milligram per week till 40 milligram, and then taper by 5 milligram per week. Some patients will require a low dose of prednisolone, like 10 to 15 milligram per day for several weeks. Because if you don't do that, they would come back with the recurrence. So when is the immunosuppressive agents is required? Nowadays, I put the patients on intermediate uveitis on the immunosuppressive agents straight away, because these patients require a very long-term treatment. So it's very important that they do not develop steroid-induced side effect. So I give either azathioprine or mycophenolate mofetil and sometimes cyclosporine. What is the dosage? 50 milligram 3 times daily azathioprine, mycophenolate mofetil, 500 milligram tablet, 2 times daily. That's 1 gram BD. And now what has happened is that there is a medical new armamentarium in our management is a dexamethasone intravitreal implant, which is called Ojudex. Particularly, it is very useful in cystoid macular edema in intermediate uveitis. The implant is placed in the vitreous cavity of the eye with a single-use applicator. It's a sutureless procedure, and you can do in OT or even in that in United States, they do in the outpatient department also. And here, this is a biodegradable polymer, and this degraded in the vitreous cavity, and after some time you won't see, and within 3 to 4 days you will see that the patient experiencing improvement of the vision. There is a chance of glaucoma in such cases, but that glaucoma is very well treatable with anti-glaucoma medication. So it's a intermediate uveitis is a puzzling disease. It's not an uncommon condition. 1 in 5 uveitis cases will be having intermediate uveitis. Careful examination slit lamp for vitreous cells, indirect ophthalmoscopy with scleral depression will be able to help us to diagnose this condition. It's a challenge to ophthalmologists. You have to individualize treatment for each patient, which one require posterior subtenon, which one require oral steroid, which one require mycophenolate mofetil or other immunosuppressive agents. And it's important. It's an early diagnosis and proper management of such condition is quite important. So any questions at this stage? Should I go ahead?
Yes, sir. Hello.
Please.
Someone has asked, Pushpa Gaikwad, she has asked management of viral uveitis.
Viral uveitis, you give the antiviral like tablet valsaclovir 1 gram 3 times daily, 1 gram 3 times daily, and along with that one antiviral ointment like ganciclovir gel is available that can be given to this patient. And such patients, glaucoma is a challenge. You need to consult with a glaucoma specialist or put the patients on anti-glaucoma treatment. And what type of the virus is causing it is important. One can do an anterior chamber tap And if we find the herpes simplex virus, then valacyclovir will be good enough. And if it is a CMV, we have to give valganciclovir.
Yes, sir. Thank you, sir. And sir, Dr. Pratik Gupta has asked when to suspect for lymphoma.
So that will come to that. Intermediate uveitis, particularly in the vitritis, if we see over 60 years, 50 or 60 years of age, not responding with the posterior subtenon, oral steroid, immunosuppressive agents, you think of intraocular lymphoma. And in such cases, you should have vitreous biopsy, particularly over 50 years of age. Usually the intermediate uveitis, we see the 20 to 40 years age group. But if we see that elderly persons having vitritis, vitreous opacity, not going with the steroid, you should consider doing a vitreous biopsy and send the material for cytopathologist. Good pathology diagnosis is required. I'll show you some cases of intraocular lymphoma. Now coming to the posterior uveitis, if I can go ahead. Any other question?
Yes, sir, you can continue. We'll take the questions after Jaideep sir's talk.
So is it a choroiditis? The question, if I see a choroiditis, posterior uveitis case, I will ask myself that how do you approach a case of choroiditis? So I ask first thing in the beginning itself, is it choroiditis or anything else? Some of the photograph has been shown by Dr. Hitesh already. And actually, this is the question should be asked yourself, because you should not miss conditions like multiple leak CSR, which can mimic choroiditis. And here the treatment is exactly opposite, where you should not give oral steroid or any form of steroid. You can do an fundus fluorescent angiogram is of paramount importance in case of posterior uveitis, particularly choroiditis. And you can see that fundus fluorescent angiogram showed point leaks, which increases in the fluorescence with leakage of the dye, seeing is a multiple leak CSR. One can have the choroiditis without much reactions, and such lesions do not cause pigmentation over the time. And if you look carefully, there is a leopard skin-like appearance in the choroiditis page. And this patient was diagnosed as tubercular choroiditis. But to me, it did not look like tubercular choroiditis. I looked into that one. There was some leopard skin-like appearance was there. And we did that fine needle aspiration biopsy. Our vitreoretinal surgeon, Dr. Mahesh Shumagam, taken a small sample. Even from the small sample, we could get that necrotic background, large lymphoma cells. So it's a very important diagnosis to distinguish a choroiditis from intraocular lymphoma. So in the case not responding to the steroid, not responding to the antitubercular treatment, you should think of an intraprimary vitreoretinal lymphoma. This is a 50-year-old lady, pain and movement of the globe. You see and white yellowish lesions over here, but if one looks carefully, there will be stria on the posterior pole of the eye over the macular area. Such stria and the complaint of pain on movements of the globe indicate there is something different, which is you should do even in a clear media and ultrasound, and ultrasound will show in the widening of the subtenon space. And that will indicate that we are dealing with a posterior scleritis. The treatment is oral steroid only, and it shows a very good resolution of the lesion. And you can see that the complete resolution of the lesions of the posterior scleritis without any pigmentation or scar. So in summary, one need to rule out at the beginning itself multiple leak CSR, posterior scleritis, even in a wet type of dry type of age-related macular degeneration or vitreoretinal lymphoma. Second question we need to ask is that whether we are dealing with a retinitis or choroiditis. Retinitis will have whitish lesion. I'll be going into the details later on. And you should see that whether the retina is mainly involved or choroid is mainly involved. If retina is mainly involved, like a toxoplasmic retinochoroiditis, the retina is mainly involved. chorioretinitis is geographic helicoid peripapillary chorioretinitis, or GHPC, or serpiginous choroiditis is a chorioretinal involvement. Here is an retinitis. If you look at the picture of it, there's lesions is white, and you cannot see the blood vessels going over it. And is a fluffy margin, whitish patch, ill-defined margin, associated retinal edema. And you will be always often seen that localized vitreous haze, overlying vitreous haze. This will indicate retinitis. Why it is important? Retinitis almost always infective, whereas the choroiditis can be infective or non-infective. Here in the choroiditis, you will see the lesions are yellowish in color, and you would be seeing blood vessels going over it. And such choroiditis will again also have ill-defined margin, and retinal vessels can be shown over it. Then you should look at that one, whether it's a focal, multifocal, or disseminated. The etiology is different in different conditions, like focal, multifocal, disseminated. If we see a focal choroiditis, you will think of the toxoplasmic retinochoroiditis if it's a localized vitreous haze, or macular geographic helicoid peripapillary choroidopathy, or macular GHPC, or macular serpiginous choroiditis. Extramacular, the lesions could be sarcoid, and if there's a geographic border, you need to think of multifocal serpiginoid choroiditis. This picture is shown a localized retinochoroiditis with vitreous haze, headlight in the fog appearance. This will give a clue to your diagnosis, and you can make the diagnosis clinically itself. And this is a toxoplasmic retinochoroiditis. We should think of first possibility as toxoplasmic retinochoroiditis. What you should do an ELISA for the toxoplasma, which will support your diagnosis. But clinical diagnosis is quite important. And here, if you put the patients on proper treatment like clindamycin or Bactrim, the patient showed a good resolution of the lesion. Fundus lesions will be seen in a week or so. But if you see a choroiditis, a geographic border, you should think of serpiginous choroiditis. Such serpiginous choroiditis is very important because many of them could be of tubercular etiology in our country. But sometimes serpiginous choroiditis can be mimicking other conditions. Like here, this is a case which was diagnosed as serpiginous choroiditis, and when is ultrasound, but the color is different. It's a pinkish color, not the yellowish color. And these margins had no retinal edema was there. And this is the other eye pictures. Ultrasonography showed that this is not a serpiginous choroiditis. It was a choroidal osteoma, and you can see that hyperreflective echoes is seen in the choroid. And CT scan showed the calcific lesion. So sometimes you need to really look into that carefully, that whether what is the color of the lesions, what is the edema of the margins, is etc. So when you see that macular threatening choroiditis, like it could be APMPP, multifocal serpiginoid choroiditis, amphigenous sarcoid TB. Here is the prompt diagnosis is of paramount importance. So particularly is a multifocal serpiginoid choroiditis, where you need to rule out tubercular etiology, because there are certain studies have shown from Professor Amod Gupta, Dr. Narsingh Rao. They have done a biopsy of the cases of some cases has been reported where the Mycobacterium tuberculosis DNA has been seen in the PCR studies. And the Mantoux test and quantiferon TB gold test is also often positive in such cases. So ancillary test, before going into the etiological diagnosis, one need to know the extent of the disease and involvement of the lesions, particularly whether it's involved macular area, whether it's active or inactive. So what are the tests we should do? The X-ray test, HRCT test, Mantoux test, quantiferon TB gold test, serum angiotensin, and in case everything is negative, you should rule out syphilis. That's doing a VDRL and TPHA test. So imaging is very important. I'm not going into the text details of it, textbook thing. So autofluorescence is quite important. If you have got this facility, you should always use it. This can help in finding out there's an active or healed lesion. I do autofluorescence routinely on all choroiditis cases. It can be used for the follow-up of the patients. You need not do an fluorescent angiogram. You can do the autofluorescence, which will help to clinch the diagnosis. Here is an example, is a macular serpiginous choroiditis. You can see the yellowish lesions. Autofluorescence showed hyper-autofluorescence seen by the blue arrows, and that healed lesions will show hypo-autofluorescence seen by the red arrows. So FFA is of paramount importance in all choroiditis or retinochoroiditis, except in active toxoplasmic retinochoroiditis, where I do not do. Many of uveitis specialists do. I find no additional information. So in case of tubercular granuloma, you can see the typical ring of fire appearance as seen in this picture in the late phase. And it's almost like, the fire around fire like a ring around a black lesion. This is often seen in choroidal granuloma. In APM-PP, you will see the fundus fluorescent angiogram hypofluorescence in the initial phase, and late stage, you will be a whole area, whole lesions will be hyperfluorescent. So diagnosis can be made by the fundus fluorescent angiogram with astute clinical observation. There is another variant is there, which is called amphigenous choroiditis. It becomes APMPP and serpiginous choroiditis. You will see the small lesions of serpiginous-like lesions. Central area will be hypofluorescence. Periphery will be hyperfluorescent. In case of serpiginous choroiditis active stage, you will see the margins will lit up with the fluorescence, and the central area will be hypofluorescence. If you see such staining pattern, you will think of that the patient is having active serpiginous choroiditis. If there is such hyperfluorescence is not seen, then it is an inactive stage. So ICG is helpful, particularly when there is a suspicion of macular involvement, because it's a larger area of hyperfluorescence that is seen clinically or an FFA. Here is an example. You see in the fundus fluorescent angiogram, macula doesn't look involved. But if you see the ICG, you can see the macula is already involved by the choroidal lesion. So choroidal lesions are much more better picked up by indocyanine green angiogram. You can show the extent of the lesions is much better way than FFA, fundus fluorescent angiogram. You can identify the subtle lesions like fundus fluorescent angiogram with the comparing with the ICG in mutes, multiple evanescent white dot syndrome, where you will see the wreath-like hyperfluorescence in the initial stage and multiple millions of hypofluorescent dots in ICG, multiple hypofluorescent dots in ICG. Clinically, you won't see the pictures of any kind of lesions. And this is what is called multiple evanescent white dot syndrome. It's also important to know the complications of choroiditis. And you should not miss a choroidal neovascularization to the recurrence of uveitis, because such patients need different kind of treatment, like anti-VEGF injection. So you look carefully, and if the earliest suspicion, you should not hesitate to do an optical coherence tomography or optical coherence tomographic angiography. Here is you can see the type 2 choroidal neovascular membrane in a case of idiopathic choroiditis. OCTA has come, and it's a novel technique to detect abnormal vasculature. I find is very useful to detect neovascularization. Here is the autofluorescence of a fundus pictures. Clinically, you don't see that any neovascularization, choroidal neovascularization. Fundus fluorescent angiogram also is unable to pick it up, but ICG also doesn't show, whereas that OCTA, you can see that network of the new vessels in the macular area, which is also picked up by OCT. If we see the diffuse choroiditis, multifocal, so all throughout the retina is expressed, is exhibited, then you should think about autoimmune etiology, and such patients will require steroid or immunosuppressive agents. There could be a mass or globular lesions or a large tuberculoma, and which can present nodules in the choroid, and this should be, one should keep in mind tubercular lesions in such cases and should be investigated for systemic tuberculosis with MANTU, quantiferon, and high-resolution CT chest. So management is of the paramount importance. You can make a diagnosis, but the patient's point of view, he should get the improvement of the vision. So the first question you ask, that is it an active lesion or is it a heel lesion? Active lesions will be having ill-defined margin, margins will be elevated, and this will be yellowish in color. Heel lesions will be flat, pigmented, margins will be well delineated. Second question is that is it infective or non-infective? So infective, if it's a tuberculosis, we need to give anti-tubercular treatment, but do not forget to add steroid because the inflammatory component will not go with anti-tubercular treatment alone. In toxoplasmic retinochoroiditis, you can need to give a clindamycin or Bactrim DS tablet. And you should add oral steroid all the time. If you see the macular threatening uveitis, you should treat with the patients or IVMP. IPMPP, we should the oral steroid. Serpiginous choroiditis, I treat with the azathioprine and steroid. After ruling out TB, if it's a TB positive, I would start anti-TB treatment along with the azathioprine and steroid. If it's a macular threatening choroiditis, the best thing is to start an intravenous methylprednisolone 1 gram daily for 3 consecutive days, followed by the oral steroid in high doses, 1 milligram per kilogram of the body weight. Because here the vision is quite important, and you can halt the progression of the disease involving the fovea by putting the patients on intravenous methylprednisolone, thereby having a very high concentration of steroid in the body. This is a report, intravenous pulse methylprednisolone therapy. I'll show a case. This is a patient came with this kind of choroiditis. Already the fovea seems to be involved. I put the patients on IVMP 1 gram 3 times daily. In 3 days after, you can see the lesions are flattened, margins are well defined. So in summary, clinical judgment is the most important. Do ancillary tests like FFA, ICG, wherever is available, get the lab workup done, get treatment started, but do not forget to have periodic ophthalmic checkup to rule out recurrence, to rule out choroidal complications like choroidal neovascular membrane. So I'll stop at this stage. And Hitesh, can you find anybody is having any questions?
Yes, sir. Sir, any role of subconjunctival injection of steroid and atropine in anterior uveitis?
No, we don't give the subconjunctival injection anymore in anterior uveitis because the topical steroid is so good penetration that you can achieve a very good therapeutic concentration and can resolve. So subconjunctival injection is not given. In case of intermediate uveitis, we give a posterior subtenon injection.
Okay. Sir, Dr. Jain has asked, what would you give to chronic patients of multifocal posterior choroiditis related to diet, health monitoring, consultation to reduce the progression rate? Like maybe he wants to know like anything specific to just reduce the progression or the recurrences. Many patients have the doubt about their recurrences, whether they are more anxious and worried about the recurrences.
So I always give an home Amsler chart, ask them to check the central vision almost every day. The first symptoms of a macular involvement, which is the quite important, is the distortion of the image and scotoma. So this is the thing we should tell. And also the patient, ask him that whether he develops any floaters in the eye. So that also will indicate that there is some vitritis, floaters, pain, and most important, any distortion of images or scotoma. So home Amsler is a very good way to find out that there is a recurrence of the uveitis.
Sir, role of CT chest in ocular tuberculosis?
CT chest is ocular tuberculosis is of paramount importance. The reason is the chest X-ray was all long time was used, and it has been found that the 40% of the pulmonary lesions are not picked up by chest X-ray, and high resolution chest CT can give that diagnosis like an hilar lesions, calcific lesions in the hilum. This has been picked up by the one, and also the parenchymal lesions is much more well picked up, which might be covered by the ribs.
Okay, sir. Thank you. Sir, I think so we can now start with the next talk and maybe take some questions later on.
So I'll just show the retinitis and panuveitis. Retinitis is quite important. It's almost always infective except Behçet's disease. It can be toxoplasma, viral retinitis, as well as the rickettsial retinitis. Retinochoroiditis with localized vitreous haze, as I told you, is the toxoplasma, second most common posterior uveitis. And then this retinochoroidal scar with the satellite lesion will indicate toxoplasma. Vasculitis with focal retinochoroiditis will indicate again a toxoplasma lesion. So you need to look carefully that satellite lesions is there or any retinochoroiditis with vasculitis is present. That will indicate, particularly chyleriasis arterialis will indicate toxoplasmic lesion. So our toxoplasma lesion is a clinical diagnosis. ELISA is required to confirm. PCR of the intraocular fluid is done in the atypical cases, and don't give posterior subtenon injection or intravitreal steroid in any case of ocular toxoplasmosis which you are suspecting. So avoid giving an intravitreal steroid or subtenon because it can become florid lesion without anti-toxoplasma treatment. In case of immunocompromised, toxoplasma can take a different look. Like, here is saying diffuse retinitis is seen in a toxoplasma case. And one should not miss what you call acute retinal necrosis, where there is a severe vitritis will be there, and in the retinitis lesion, which will start from the periphery with like a wedge-like fashion. And this is an emergency situation. You need to make the diagnosis and put the patients on intravenous acyclovir or intravenous intravitreal ganciclovir. So if it is a facility is available, you can do an anterior chamber tap or vitreous tap for polymerase chain reaction for herpes group of viruses, herpes simplex, herpes zoster, or cytomegalovirus. So here is the case of acute retinal necrosis, which was treated with the intravenous acyclovir. After that, followed by the barrage laser when there's a resolution over there to save the posterior pole of the lesion. Sometimes it can go to the retinal detachment, and you need to do a vitrectomy and silicone oil injection, intraocular silicone oil tamponade. It's a real emergency in uveitis. This fast track diagnosis and management. This is which also is important to know that immunocompromised patients, you should keep the possibility of cytomegalovirus retinitis, which has got typical appearance of retinitis with hemorrhagic patches. Often pizza pie-like appearance is seen in cytomegalovirus retinitis. If cytomegalovirus retinitis doesn't occur in immunocompetent patients, is always seen in immunocompromised patients like HIV or AIDS or transplant patient. One can get what you call is that progressive outer retinal necrosis instead of having the peripheral lesion, you will have that lesions is the central part of the retina and vessels are spared. And this is a very dangerous disease, and it's a very severe vision threatening disease. Visual prognosis is often very poor. This is a cracked mud appearance you will see, and this is called progressive outer retinal necrosis. But you may sometimes come across something which we may not be able to make out, like this case, where there's only presentation of the vitreous opacity with the retinitis lesion. And here in such cases, you should add an investigations like syphilis investigations, like VDRL, TPHA, and you can find out that some of the times this can come out with a syphilis, as is seen in this case. So sometimes we see that the patient following fever, like typhoid, dengue fever, come with cottonwool spots, necrotizing retinitis with hemorrhage and soft exudates. And such conditions is called post-typhoid or post-fever retinitis. It could be dengue, rickettsia, or typhoid. They note specific treatment as required. Fortunately, they respond to that oral prednisolone and treatment of the underlying disease. So in summary, a good clinical history is very important. Know whether it's immunocompetent or immunocompromised, history of fever, and when available, PCR of the intraocular fluid, and treat the underlying disease.
Thank you, sir. That was an excellent presentation.
I'll just finish that panuveitis few slides. Can I?
Sure, sir.
So panuveitis, just few slides of panuveitis practical part. This is a 35-year-old female, is sudden dimness of vision in both eyes, headache and tinnitus 1 year back. You see that the KPs are mutton fat KPs. But most important, if you look at the fundus, disc edema or papillitis will be seen with a serous exudative retinal detachment. In such cases, as the first opportunity, you should do an ultrasound, which will show choroidal thickening. No lab investigations is required. B-scan ultrasound is required. Fundus fluorescent angiogram and sepsis OCT. Ultrasound B-scan will show diffuse choroidal thickening in the posterior pole, and especially in the juxtapapillary region. And if we do a fundus fluorescent angiogram, multiple punctate hyperfluorescence lesions are seen at the level of the retinal pigment epithelium. And later on, it showed multilobular pools of dye separated by the dark rim. And sepsis OCT, which Hitesh has worked with me, it showed the subretinal fibrin with safety formation. And this responds to the treatment, and you can assess the treatment response by doing a repeat sepsis OCT. Its close differential diagnosis is bilateral multiple like CSR, ultrasound and FFA and OCT will differentiate. And sympathetic ophthalmia will have obviously history of penetrating injury or surgery, but otherwise it will mimic the similar picture. The treatment is the IVMP 1 gram daily for 3 days, followed by the immunosuppressive and oral steroid like azathioprine 50 milligram 3 times daily, and the treatment is around 6 to 9 months. So you don't see this kind of lesions like vitiligo, poliosis, alopecia at the beginning. It may develop in the later stage of the disease. This is another case, 20-year-old male, marked dimness of vision in both eyes. They have always the history of oral or genital ulcer, and there is erythema nodosum in the leg, and the patient will give history of oral aphthous ulcer and sometimes genital ulceration, and such patients can have cold hypopyon, mobile hypopyon, and retinal vasculitis, optic disc pallor, vitritis, retinitis lesion. You should suspect Behçet's disease, and you may do the HLA-B51, but which is not a must, but a clinical diagnosis with a good history and anterior segment and fundus examination may clinch the diagnosis. Fundus fluorescent angiogram is showed typical fern-like hyperfluorescence, petaloid fern-like hyperfluorescence. Biologics is often used in such cases. If not available, you should put the patient on cyclosporine and azathioprine. Steroid alone will not help. This is a 43-year-old male, dimness of vision, diagnosed as CMV retinitis, HIV positive, treated with intravenous ganciclovir. I shake hands with the patients routinely. This patient was from Bombay, actually. I found something wrong in the hand, and there was a dermal lashes were there in the hand, and it was a case of syphilis with subretinal deposits. And the patient was RPR and TPHA came positive, treated with intramuscular injection penicillin, and you can see the dramatic response with the treatment for the syphilis. So panuveitis with subretinal exudates will be, one should keep the possibility of syphilis. Last case is the patient which I seen for about 30 years back with a bone injury in one eye. other eye of this patient from the Bihar lost the vision with the exudative retinal detachment. I put the patients on azathioprine and steroid. It came back, it became normal. The visual acuity, the retinal lesions, exudative RD and disc edema subsided. The patient is now doing postdoctoral fellowship at Finland. He got my email and wrote to me that I'm doing postdoctoral fellowship at Finland, and this is his picture. So I'll end up with this one, the Vogt-Koenigsegg Harder disease, tuberculosis, sarcoidosis, Behçet's disease, sympathetic ophthalmia, syphilis is the panuveitis diagnosis. So lastly, the don't miss and diagnosis of endogenous endophthalmitis, as Dr. Natarajan has seen. Take a good history, IV infusion, history of HIV, immunosuppression is important. So most vision-threatening uveitis is the endogenous endophthalmitis. Take a careful history. Ancillary test is important. Aggressive treatment is required. Thank you very much. If there is any question, I can take up the question at this stage.
Oh. Sir,
it's exhaustive talk.
Thank you, sir. Excellent talk, sir. Sir, shall we take questions after Jaideep's talk?
Yeah.
Yes, sir. Thank you, sir. So I'll request Professor Natarajan sir to introduce Dr. Jaideep.
Can I share the screen for a second?
Yes, sir. Sure.
Yeah. But, yeah. Okay. So I just can you see the screen?
Yeah.
Yeah.
Yes, sir.
So I'm happy. This is the opening of the Dr. Hitesh Sharma's clinic, where Dr. Bishwas is there, and my grandmother came and blessed, and you can see she's there. You can see JB?
Yes.
Okay. So thank you, and thank you, JB, for doing this for Dr. Hitesh and Aditya Jyot. And I'm glad to introduce Dr. Jaideep Polanchkar, and I know his father also. He's an ophthalmologist, and he did his DNB with Aditya Jyot. So I'm glad he's a bright student from Aditya Jyot, went to Shankaranayathala, did his fellowship in vitreoretinal surgery, and I got good recommendation from Dr. Rajiv Raman, his teacher, and Dr. Pramod Bende. And he worked very well in Shankaranayathala, specifically on ROP and everything vitreoretinal surgical branch. And also he was a great organizer for the conference in Shankaranayathala, and I'm glad he did the same for ROP in last September. This year, because of COVID, we were only in webinar. And he's a great vitreoretinal surgeon. I think I'm glad to say, like how Dr. Vajnath told for me, he's a better surgeon than me. And here we have Dr. Jaideep Polanchkar.
Thank you, sir, for the very kind words. I'm truly blessed to share the screen with two great stalwarts in the field of ophthalmology. One yourself in retina, and Dr. Biswas, the JB sir, who fondly call him in UVA. And it's my pleasure to give this talk, and I thank Dr. Hitesh for inviting me. So I'll just share my screen quickly. Can I begin, Hitesh?
Yes, sir. Sure.
So I'll be talking on a topic which is slightly different from purely a vitreoretinal point of view, and I'll be talking on vitreoretinal surgery in uveitis. So for a brief introduction, we all know, I think for the last 1.5 hours, we have been listening to all the kinds of uveitis and different entities which can present, and there are many forms which Dr. Biswas, Dr. Hitesh showed have severe forms of uveitis which are vision threatening, and really identification of these syndromes is not so easy, and it's important to determine what treatment and what is the prognostic implications in these disease entities, and without knowing what we are dealing with, we really can't go ahead. So there are many diagnostic dilemmas which can arise in these kind of cases which have an atypical history, clinical presentations, and inconclusive diagnostic workup, and they can present with persistent or worsened inflammation in spite of maximum immunosuppressive therapy. So in such cases, more invasive intraocular testing is indicated. And in such situations, particularly infectious etiologies and atypical uveitis, if there is a delay in the treatment, it may result in worsening of the patient's disease with a poor visual outcome. So that brings us to vitreoretinal surgeon's role. And the first report of a pars plana vitrectomy in case of uveitis was published way back in 1981. And it demonstrated that almost 75% of the patients in that series had visual improvement post vitrectomy. So vitrectomy is beneficial both as a diagnostic tool as well as a treatment entity in uveitis. So among the reported benefits, we have various things like vitreous opacities can be removed. We will remove the inflammatory mediators which are in the vitreous. There will be repair of associated complications such as epiretinal membranes, macular holes, or retinal detachments. So when it comes to diagnosing, the most frequent invasive procedures we do are anterior chamber tap or vitreous biopsies, but not always they give us a good yield or result. And I think less than 50% or almost 50% of the times we get to the diagnosis, but many times we do not understand what is the entity. And then comes the role of vitrectomy, because it gives us a larger vitreous, gives us a larger volume, of course, and as well as a good yield of the infectious agents or other markers which are causing the uveitis. So vitrectomy in uveitis is definitely unlike other routine vitreoretinal surgery. So we need to have some special precautions or tips when we are dealing with such surgeries. And also, it is important to consider controlling the inflammation in the perioperative period. So here I want to share one large meta-analysis of vitrectomy in the treatment of uveitis published in American Journal of Ophthalmology in 2005. And what they concluded after evaluating almost about 1700 odd eyes, that there is a visual improvement in about 68% of the patients post vitrectomy. About 20% have unchanged vision and only 12% have worsened vision. So what it technically shows us that almost 90% of patients do well post vitrectomy in situations where medical therapy is not exactly improving their condition. Also, it helps to reduce the systemic medication after the vitrectomy because of decreased inflammatory load and infectious load. The role of vitrectomy also is in reducing the cystoid macular edema in these cases. So almost 50% reduction in cystoid macular edema was noted in this meta-analysis in patients who underwent vitrectomy and who had preoperative CME. Coming to the indications of vitrectomy in uveitis can be both diagnostic as well as therapeutic. In diagnostic, when we want to do biopsy, like a vitreous biopsy or a chorioretinal biopsy, we need to do a vitrectomy. When AC tap or other fine needle aspiration biopsies or vitreous taps have not yielded sufficient results or positive results, then we need to look at vitrectomy to get to the infectious agent, or what is the pathology. Therapeutic vitrectomy can be indicated in cases of media haze like pupillary membranes, complicated cataracts, or inflammatory membranes which form over intraocular lenses, precluding good visualization of the posterior segment. It could be vitreous related because of vitreous inflammation or vitreous hemorrhage, as well as vitreous debris in cases of healed uveitis, and also in cases of endophthalmitis, where the vitreous has been has infection and hence we cannot see the retina. When it comes to intraocular pressure abnormalities, both raised intraocular pressure or hypotonic could be indications for vitrectomy in appropriate cases. Retinal detachments, definitely of all types, will eventually need vitrectomy, except for exudative retinal detachment, where we need to take a cautious approach, and the last resort is a surgical approach. Macular abnormalities like cystoid macular edema, epiretinal membranes, and macular holes may need vitrectomy. Cystoid macular edema, again, it's a last resort. In cases of parasitic infestations, like cysticercosis, toxocariasis, caterpillar hair, and so on and so forth, may require therapeutic vitrectomy. Malignancies like intraocular lymphoma may require vitrectomy to yield either diagnostic or as well as therapeutic because of vitreous inflammation. And lastly, surgical removal of CNVMs, but this is largely abandoned, and we have good anti-VEGF agents now to treat inflammatory CNVMs. So as we all saw in the presentations before me, uveitis is not something as straightforward as other ocular conditions, and it's like an enigma. And often what we start off with as a diagnosis or treatment turns out to be totally something different at the end of the disease, at the end of the treatment of that eye. So here comes the role of a VR surgeon. So vitrectomy as a diagnostic tool can be used in specific where specific diagnosis is not known, and nearly half of the patients we may not know the diagnosis at the beginning, or we may be treating empirically, or may be treating something which may not be actually there inside. So it's a very important diagnostic tool. It also administration of immunosuppressive therapy or anti-infective therapy in such cases may actually prove harmful, because if you treat something in the wrong way, like Dr. JB was saying, if we treat something with steroid and steroid is contraindicated in that particular disease, it may actually prove harmful. So as a diagnostic tool, pars plana vitrectomy may help in the diagnosis and also the further management. The indications are atypical uveitis not responding to therapy, suspected infection, and malignancy. It also helps to clear the media, removing the vitreous opacities and the toxins and infectious elements in the vitreous. And lastly, sometimes relieving the traction, like tractional retinal detachments or traction cause vitreomacular traction, and also aid in better drug delivery. So the indications for diagnostic vitrectomy can be infectious as well as non-infectious.
किया पंखा काजल वो बैठने का
Vitreous
कुर्सी
biopsy, this is a procedure how we do the vitreous biopsy, but I would not like to go into the details of it, except for the fact that vitreous biopsy, I would like to just say that vitreous biopsy is not very often done, or at least in Shankar Netralaya we were not taught not to do it so frequently, because vitreous biopsy has some risks. So when can you do it? When you don't have a setup for a vitrectomy, where you cannot do a vitrectomy, in those settings where your antechamber tap has come out negative and you don't know how to go about, then you can consider doing a vitreous biopsy, and it's done with a larger bore needle, comparatively 23 to 25 gauge needle, with attached to a 2 cc syringe, and you make a pars plana entry at about 3 to 3.5 millimeters depending on the phakic status, and you direct the needle towards the center of the globe and try to aspirate at least 0.1 to 0.2 cc of vitreous fluid. So if there is a dry tap, you can change the direction and then try again, but too many tries should be avoided, because any traction caused to the vitreous can lead to future retinal detachment. So in case you get a dry tap once or twice, after that second attempt you should not go for more attempts. It works well in case of liquefied vitreous in the elderly age group or in high myopes, where the vitreous is syneretic and you can get some vitreous, but in younger patients with formed vitreous, you seldom get a tap. So here is another technique where you can do a biopsy using a disposable cutter, 23 gauge or 25 gauge disposable vitreous cutter, with an inbuilt infusion and aspiration available, which has to be done manually. So, but again, you are needing a vitrectomy machine to function in this setting. So you should take at least 1 cc of undiluted vitreous sample and making sure there is no hypotony. So you need to judge clinically how much vitreous you can aspirate without causing hypotony and its inherent complications. So there was another machine which was introduced about a decade back or so, I can say more than that, and I'm sure Dr. Natarajan will be knowing this machine, and it is called the Intractor. So this had a inbuilt cutter, aspiration, and infusion all in one. And it was a battery operated system. It has a separate power unit, and it eliminated the need for having a connection to a vitrectomy machine. And you could collect the sample, and this is how you can collect. Two assistants are required, one for aspiration, one for infusion, and you can take a vitreous biopsy with this interactor, which is far safer than a vitreous biopsy. So then it comes to vitrectomy, pars plana vitrectomy. So standard 3-port transconjunctival pars plana vitrectomy with a 23 or 25 gauge system is generally what is recommended and is used. You can also do a 2-port vitrectomy where the infusion cannula has an inbuilt light system in place. So what is done is you need to connect a 3 ml syringe to the aspiration outlet of the vitreous cutter with a 3-way stopcock, and then you go to the anterior mid vitreous and start the cutting, and aspiration is with the syringe. And then this is an undiluted sample, so before you turn on the infusion you need to collect this sample, and taking care there is not a lot of hypotony because that can cause choroidal detachment and effusion. You take the undiluted sample and immediately you need to put on the infusion to restore the IOP. After you've taken the undiluted sample, then you take a diluted sample in a 10 cc syringe. About 10 cc of undiluted sample can be collected. So after collecting the sample, you need to turn on the infusion. Already, as I described. The other thing which can be done, if you are using a disposable cassette and tubings, you can send the entire set of the cassette and the tubings for analysis. After you do this, complete vitrectomy may provide a better diagnostic sample, because in case you are looking at certain conditions where the inflammation is in the retina or subretinal, then the yield is better when we go as close to the lesion as possible at the surface of the retina. So the cortical vitreous there needs to be collected, and that will give us a better yield, like in cases of a lymphoma. The cut rate when you do a vitrectomy in such case, when you're collecting the sample, it needs to be low to start with, because you need to preserve the cellularity when you're collecting the sample. A high cut rate often damages the cells, viable cells, and may, especially in cases where you need a cytology, like a lymphoma, you may need to go as low as 300 to 500 cut rate. So the cutting rate should be kept low, and you need a high suction so that you get a good undiluted vitreous sample. So what do we do with the specimen? After we need to, prior to this surgery, we need to coordinate with the laboratory people and make sure that they are available, waiting with the necessary equipment or the sample bottles outside the operation theater, so that you can directly hand over the sample to them, so that there is no delay in processing the samples, because they start losing their viability. In case it is done at some time when the laboratory is closed, then you will have to preserve the samples, and they need to be preserved in a refrigerator in the door segment, not in the freezer. You should never freeze these samples. That is very important. So at 4 degrees in the door of the refrigerator, you can keep the sample. And the sample which are to be cultured, you need to inoculate directly. You should have plates and the liquid media in your operation theater, where you can directly inoculate the vitreous on these plates and liquid media. In case of chorioretinal biopsy, you need to send you can do it via transscleral approach also, but now pars plana approach is much favored because of reduced risk of the retinal detachment and vitreous hemorrhage. Chorioretinal biopsy is seldom performed, but there are certain cases where you really need, you're not getting any diagnosis and the lesion is subretinal or in the choroid, where you need to get the sample directly from the tissue, where the affected tissue, So it is generally preferred to do in the superior quadrant superotemporally, because you need to put a gas tamponade, and that area where you have removed the small chunk of retina and choroid, you'll need to laser it and put a gas tamponade. So it is done with the help of vertical scissors or a diamond blade, and a square portion of 1 millimeter or to 2 millimeter square portion of the suspicious retina and choroid is excised after diathermy, and then the surrounding laser barricade is done, barrage is done, and intraocular gases like SF6 or C3F8 is injected as a tamponading agent. So what do we do with the undiluted and the diluted sample? Generally, the undiluted sample is used for stains and smears, and also for the PCR testing, whereas a diluted sample can be used for cytology analysis, and in certain cases it can be centrifuged and used for special stains for cytology. In case of non-infectious condition. In infectious conditions, again, undiluted sample is used for smear and PCR, and diluted sample can be used for culture. So this was diagnostic part. Now we come to the therapeutic vitrectomy. So what are the indications of a therapeutic vitrectomy? Mostly media opacities like a cataract or vitreous opacities, endophthalmitis, which is uncontrolled with medical management, lens-induced uveitis, inflammatory, poor inflammatory control with systemic therapy. To manage complications of uveitic entities like epiretinal membranes, retinal detachments, cystoid macular edema, macular holes, tractional retinal detachments, and so on and so forth. Sometimes raised IOP or hypotony may require therapeutic vitrectomy, and sometimes also for sustained intraretinal drug delivery. So controlling, whenever we do this therapeutic vitrectomy, controlling the inflammation in the perioperative period is paramount, because if we don't have a steroid cover or immunosuppressive cover, then you can end up with disastrous consequences because of aggressive inflammation post-surgery. So we need to use judiciously systemic steroids and immunosuppressive therapy before and after the surgery. So there are certain conditions like Dr. JB sir just said, acute retinal necrosis, they are true emergencies. So what we need to do here is prompt interventions, and especially when there is a retinal detachment associated with acute retinal necrosis, you need to intervene and you need to operate. So uveitis in hazy medias where you need vitrectomy could be pupillary membranes, complicated cataracts, dense posterior capsular opacities and membranes with vitritis, where you cannot see the retina. So here we need to combine these membranectomy procedures along with the vitrectomy. The smaller incisions are preferred here to prevent IOP fluctuations, and viscoelastics may be used to, in case of phakic cases, especially if you don't want to, in the anterior segment, when you want to dilate the iris and remove the posterior synechiae, you can use viscoelastics to break the synechiae, because you may damage the anterior capsule if you use any sharp instruments. So trauma to the anterior capsule has to be avoided in phakic eyes. And lens should be spared as much as possible because it helps to compartmentalize the anterior and posterior segments. So it's better to spare the lens whenever you can. Whenever you want to remove the lens, in case of patients who had resolved inflammation, phacoemulsification is the preferred route. However, in cases of emergencies, you may need to consider doing lensectomies. IOL selection is basically you have to avoid IOLs, silicone IOLs, and heparin-coated IOLs. So what are the abnormalities which may require VR intervention? One of them is epiretinal membrane. So this is a complication which is often noticed after the disease is quiescent and inflammation is gone, but causes significant visual morbidity to the patient. So epiretinal membrane removal along with vitrectomy is warranted in such cases. However, we have seen that the vision generally doesn't improve much in such cases because of long-standing nature, and already some damage due to long-standing inflammation is there in the macular area. But nonetheless, there might be improvements in the distortion or metamorphopsia of these patients, and it's worthwhile removing these membranes. Again, this has to be done only after the inflammation is controlled, and we give a gap of at least 3 months before we consider doing a surgical intervention in such cases. The other thing is the cystoid macular edema. Again, we have excellent medical management when it comes to cystoid macular edema of uveitic or inflammatory cause, but sometimes CME can be refractory to all kinds of treatment, medical treatment, and there could be some associated vitromacular traction, which is the reason why the CME is not resolving. And in such cases, vitrectomy can be performed in such recalcitrant cases. So again, the visual benefit is guarded, and surgery can improve the anatomical architecture, but certain damage is there, and the visual improvement is not satisfactory. Lastly, there's macular holes. Macular holes are again seen in about 2.5% cases of uveitic origin. The treatment is the same as any other macular hole, except that you need to control inflammation, make sure that the inflammation is controlled for at least 3 months, and then plan the macular hole surgery. So here is a case of macular hole, which was treated, but again developed CME and then was treated with IVTF. Next, we come to a complication that is the most devastating complication in uveitic cases, that is retinal detachment. And we have seen that the risk factor for retinal detachment is present with uveitis as an independent risk factor. And complicated retinal detachments are often seen in cases like CMV, retinitis ARN, PORN, and tractional retinal detachments are seen in cases like toxocariasis, toxoplasmosis, pars planatis, and entities with retinal neovascularization like Eales disease or retinal vasculitis. So these may be successfully repaired in a high percentage of cases with the vitrectomy techniques of the current generation, and you may or may not require buckling procedures associated along with these vitrectomy procedures along with tamponades. So the first entity is acute retinal necrosis. Acute retinal necrosis, as I told you that it has a very high chance of getting a retinal detachment. I think more than 50% patients who develop ARN eventually have a retinal detachment either in the acute phase or in the later phases. So these patients need to be constantly monitored by the VR surgeon, and also we need to have a close observation of the other eye, because it's quite likely that the other eye may develop acute retinal necrosis in the course of the treatment. So there are certain studies which show that early vitrectomy does prevent retinal detachment in cases of acute retinal necrosis, but there's not significant change in the visual acuity, final visual acuity. Hence, vitrectomy in ARN is generally indicated when you see a retinal detachment or when there is some other associated complication where vitrectomy is warranted. Generally, in such cases, the tamponading agent used is a silicone oil, and the retinal detachment generally starts at the edge of the necrotic and the normal retina. So it's very difficult to visualize the breaks in such cases because of the extensive retinal necrosis, but they are generally found during the procedure, during the vitrectomy procedure, and proper barrage laser has to be done around these breaks. And in case you don't find a break, you can consider doing a posterior retinotomy and then settling the retina, and laser along the entire edge of the necrotic, at the border of the necrotic and normal retina should be done. But laser should always be done only on the healthy retina, because if you do it on the necrotic retina, it's likely to disintegrate. The next condition is PORN, and again has a high predisposition for getting retinal detachments. So retinal detachments, I will just go through this. Retinal detachments are again also seen with AIDS patients, almost in 20% of them with retinitis, and may develop it bilaterally. In these treating these cases, also associated scleral buckling is not very successful, but encirclage like a belt buckle is often used in such conditions because uh, there are often there could be missed breaks in the periphery, and because of the inflammation and tractional component, peripheral belt buckle or encirclage is warranted in these cases. Sometimes the rhegmatosis detachments may not even extend up to the ura or maybe in the area of the necrosis itself. So these subtle factors we need to look into when we are treating the retinal detachment. So when it comes to the actual procedure, the most important factors that need to be considered is first is how is the media clarity, and in case the media is not good, you need to clear that. Posterior vitreous detachment is generally not present in these cases because most of the patients are of the younger age group, and the posterior vitreous PVD is generally quite adherent because of the severe inflammation. So this is a very crucial step in the surgery, and it's must to induce a posterior vitreous detachment in these cases. So you need to be very careful while doing this because there is a necrotic retina and a normal retina, and it's very easy to uh, cause large breaks or tears when you're trying to induce the posterior vitreous detachment if you use high suction and you are going close to the inflamed retina, and it can have disastrous complications, especially close to the optic nerve head or the macula. So removing the PVD is also very important because it is a source of inflammatory mediators which can in the future result in recurrent CMEs and ERM formation. So that is why you should make sure that you remove the PVD. Injection of intravitreal triamcinolone during the surgery helps in better visualization in such cases and also helps in the post-operative control. So you can use it liberally. Safe debulking of the vitreous with clearing of the peripheral membranes and traction is the key to the good vitrectomy. So we need to weigh the benefits of whatever procedure we are doing, pros and cons. You need to remove as much vitreous as possible, but safely without causing any peripheral breaks or other complications, because any kind of breaks in the periphery, especially in the inferior retina, often lead to recurrences in these conditions. So at all costs, you need to avoid getting such complications intraoperatively. So as I said, belt buckling helps to support the peripheral retina and prevents traction. So you need to use it judiciously, and most of the patients with inflammatory retinal detachments, I prefer putting the belt buckle. The cut rate needs to be high, and suction needs to be just about adequate when you are doing vitrectomy. The posterior retinotomy, as I said, can be made in case it's difficult to identify anterior breaks or the causative break, and it can be made at the junction of the healed and active retinitis and the normal retina. Generally, in such cases, the use of perfluorocarbons like LPFC is warranted because the retina has multiple large breaks and it's difficult to do a fluid gas exchange, and PFCL or LPFC just helps to flatten the retina. But it has to be used very judiciously because large breaks also mean that this perfluorocarbon can flow under the retina, and you have to avoid that under all costs. So you need to use it very judiciously and carefully over the posterior retina only. The periphery needs to be examined at the end of the surgery to make sure there are no missed breaks or traction, and before you perform the fluid gas exchange. And then retinopexy needs to be done to all the breaks and all necrotic areas, as Dr. Vishwas has just shown us a case of ARN. Necrotic areas can be walled off with laser so that to prevent the necrosis from spreading posteriorly. Laser treatment of CME retinitis again has been unsuccessful for the spread, but in acute retinal necrosis it does help. Silicone oil is the preferred long-acting tamponade. in such cases, and gas is seldom used. In my experience, using gas also has its drawbacks because a lot of inflammatory mediators get sequestered posteriorly. As the gas bubble starts decreasing, all of them will go and settle inferiorly, and inferior recurrent retinal detachment is very common in such cases when the gas is used. So early vitrectomy is warranted for ARN if you are suspecting that these patients are going to develop retinal detachment. And it allows for removal of the inflammatory mediators and any kind of vitreous traction. Then we come to parasitic infestations. So I will not describe the presentations, but generally the most common ones are toxoplasma, retinochoroiditis, toxocariasis, and so forth. So surgical intervention is generally most commonly warranted in cases like toxocariasis or some things like cysticercosis. So indications for surgery will be severe post-inflammatory complications such as persistent vitreous opacification, retinal detachments, or epiretinal membrane formation with vitreomacular optic nerve traction, endophthalmitis, and tractional retinal detachments. So here you can see a case of toxocariasis where there is a tractional detachment involving the posterior pole, and post-surgery the traction is relieved and with a good visual outcome. Again, cysticercosis is a very good indication for vitrectomy whenever the cysticercosis is in the vitreous. So it causes inflammation, and it's very likely when the cyst will rupture, will cause very severe inflammation, and it's often difficult to save such eyes. So it's very important to remove this cyst in toto before they rupture intraocularly. The most common approach is the Parshplana route, and vitrectomy is done with the removal of transvitreal and subretinal cysts also if we encounter them. And sometimes subretinal cysts can be removed transsclerally also in case they are at the posterior pole and it's very difficult to remove them. But rarely, not at the posterior pole, peripherally, we can consider doing a transscleral subretinal cyst removal. But ideally, it is better to remove them along with the vitrectomy procedure. So lastly, I will just end with saying this. This is all what we saw where vitrectomy will help when it comes to managing uveitis. But sometimes even a vitreoretinal procedure or a surgery may cause uveitis. So this is an article we published from Shankar Netralaya. And here we found out that vitreoretinal surgery with or without antecedent penetrating trauma can give rise to inflammation, not only in the inciting eye or the other eye, with the sympathetic ophthalmitis. And this is something which we need to keep in mind when we are doing vitreoretinal surgery. So with that, I'll conclude by saying that vitrectomy represents a critical tool for the appropriate diagnosis of the underlying cause of intraocular inflammation, as well as it helps as a therapeutic option to restore vision for patients through removal of the media opacity and restoration of the retinal architecture. And currently, with the use of the smaller gauge instrumentations, it allows improvement on previous techniques of diagnosis as well as treatment, and they are very safe. Whenever we contemplate doing any vitreoretinal procedures, we need to make sure the perioperative inflammation is controlled with immunosuppressives or systemic corticosteroids. And lastly, I would like to conclude by saying that vitreoretinal surgeons should always be kept in the loop when you're managing severe forms of uveitis, and timely and good intervention by a vitreoretinal surgeon can go a long way in not only diagnosing the condition correctly, but also in the treatment and finally good anatomical and visual outcome for the patient. So I thank you with that for the patient hearing.
Thank you, sir. It was a nice
Is
talk.
there any time for any videos, Sitish?
Yes, you can, sir. Actually, JB sir had to attend one more webinar. So
Okay.
he just left the webinar.
Okay.
So you
He's
can
gone?
complete the videos.
He's gone, Hitesh?
Yes, sir. Just left actually.
Okay.
I had to attend the webinar at 8 p.m.
Jaideep and Hitesh, you also have to excuse me. Shivanandan sir has come. So
Oh,
you proceed. Show the video.
okay, sir.
Okay, okay, sir. Okay, sir. I'll just briefly run through the video. This is a video of a patient with the toxocariasis who has a granuloma posteriorly and a tractional retinal detachment. So this is basically there is a opacified vitreous with an incomplete posterior vitreous detachment and vitreomacular traction. The granuloma is actually having adhesions with the vitreous, which are currently being cut so that we relieve the anteroposterior traction. Then a good vitrectomy is done, and then we go to the posterior pole where the granuloma is present. All vitreous adherents or attachments to the granuloma are removed carefully before we start dissecting it. And a curved scissor is used to carefully remove this granuloma in toto without causing any retinal breaks or traction. And here you can see bimanual surgery being done with other hand having the forceps holding the granuloma, and then the granuloma is completely removed and it's cut with the cutter and removed. Now the remaining portion of the granula, which is not possible to cut, it's calcified, so it has to be delivered through the sclera by enlarging the incision like a IOFB. Ultimately, fluid gas exchange is done and laser is done, and we use a gas or oil tamponade. In this case, oil was used. So that was a toxocariasis. Now I'll just share a video of a cysticercosis. So this is a case of intraocular or vitreous cysticercosis. You can see the cyst floating in the vitreous cavity, and again here a careful vitrectomy is done, and all adhesions of vitreous are removed from the cyst, making sure that the cutter port is away at all times, so away from the cyst, because the cyst can easily come into the port and rupture, and the rupture of the cyst inside the eye should be avoided at all costs because that will cause severe inflammation. So once the all vitreous adhesions are removed and peripheral vitrectomy is completed, the cyst is carefully delivered from the sclerotomy in toto, making sure it doesn't rupture. So then vitrectomy is completed and endolaser is done and periphery is examined, and we can use gas tamponade in such cases. So here is another case where there is a vitreous hemorrhage along with a retinal detachment in the patient of Eales disease. So again, vitrectomy is to be done carefully, making sure that you don't damage, because there is no view of the underlying retina. You cannot distinguish the vitreous, thick opacified vitreous from the retina. So you have to be very careful when you're doing vitrectomy and go very layer by layer when you're removing the opacified vitreous, because the retina is right underneath and you might cause large breaks if you don't see the retina. So generally you start on the nasal side and make a opening into the thick opacified vitreous with the vitreous hemorrhage, and then through that opening remove all subhyaloid bleeding, and then proceed 360-degree from there circumferentially, remove the entire vitreous, and then go ahead and manage the retinal detachment. So here there is subretinal hemorrhage as well, and there is a retinotomy which is being done, and the subretinal hemorrhage is being removed. There was PVR changes where some membrane peeling was done. Here we are injecting liquid perfluorocarbon to stabilize the retina. once the retina is mobile, you can settle it with the perfluorocarbon liquid, do the laser along all the retinotomy edges and break, and end with the silicone oil. So that is all I wanted to share today. So over to you, Hitesh.
Yes. Thank you, sir. Videos. Unfortunately, JB sir had to leave as he had to attend one more webinar. So,
Oh, okay.
and maybe we can organize a bigger one when he's free and maybe invite some more speakers.
Certainly, certainly.
So, I think we should conclude the meet and the webinar and
Yes.
yes,
Sure. Maybe we can have part 2, and that time we can probably have more topics.
surely, sir, surely. Thank you, sir. And Natarajan sir also had to leave. And he had some work. So thank you everyone for this wonderful
Thank
day,
you.
especially on a
Thank you,
Sunday
Hitesh.
evening when everything is unlocking. And thanks everyone for this webinar, the IT team of the Aditya Birla Hospital, the Centaur Pharmaceuticals who have helped us, and especially Mr. Anil who has done wonderful job in making the flyers and inviting everyone. So, and Samir from the IT department. So thank you everyone, and you can mail us for any doubts or any queries. So that is available on our websites also. So we'll come back with one more, maybe bigger webinar. Thank you. So everyone have a good day.
Thank you, Hitesh.
Thank you.
Thank you. Good night.